Good morning. Now it's my time. So next, please. I'm going to talk about early trauma and PTSD. I think in what I'm going to talk in, and I decide to do a different presentation. I'm not presenting my own data, but what are my reflections about them. So it's a little bit different. Let us see what's going on. I got some videos from YouTube. As I have a teenager boy, I learned how to do it. Many of them are from Professor Suomi. He's a very important professor at Washington, D.C., and work with primates. And one is from Professor Tronick. Next, please. Here's what I'm going to talk today. First, early trauma as a risk factor for PTSD, then social adaptation and human development, stress hyperresponsive periods, maternal shield, development of ability to recognize emotions, memory, somatic marker, parental bonding, teaching emotions, early trauma, impairing social adaptation, and traumatic events on adults with early trauma history. Next, please. So we know that dysfunctional parental bonding and negligence and abuse are high-risk factors for some mental disorder development during adult life. But which are the underlying mechanisms on it? We know that there are many scientific evidences showing that early trauma is related to enduring modifications on glucocorticoid receptors, like decrease in new formation of GRs, and different sensitivity according to the timing when the trauma happened. And also, this functioning is dependent of some performance. But we know that. No, next, please. Next. Sorry about that. Next, scientific evidence, sorry, I'm going to repeat, that early trauma is related to enduring modifications on glucocorticoid receptors, like a decrease on new GRs formation, and also depending on when the trauma happened, there are different sensitivity. Also, depending on some polymorphism, the GR will function differently. Next, please. So we know that early trauma is a PTSD risk factor. Traumatic experience during childhood are strong predictors of PTSD. Some authors, like Post and Weiss, has a theory, a sensitization theory. Early trauma lead to persistent alteration on a stress alarm system. Next, please. But there are other ways to understand the role of early trauma as risk factor. How can we link early trauma to PTSD? Next, please. We take a look on psychological human development that is guided by a universal rule of evolution as individual and species survival. And also, cultural changes have influences on human development. Next, please. Our societies are very complex, and to have a social adaptation on it, we need, in survival, we need to develop some skills. Interpersonal relationships have several possibilities. Motivations and means were diverse according to culture and language. So for a better social adaptation, better the social adaptation, better will be the survival and success in the group. Next, please. For human social interaction, language is fundamental in our complex social system. Rules and laws governing the social system, acquired transgenerationally through speech and written material, and is transmitted also by nonverbal behaviors like care, support, negligence, and threat. Next, please. For all of that, we develop a lot our brain. Here is our brain comparing to another primates. And we will see that despite they are the same weight, our brain is much bigger, even the neocortex and the white matter. Next, please. So for all this development, the human development, including social adaptation, is very slow. The better early environment and parental modeling, the best will be further ability to interact. Vertebrates present a hyper-responsive period to stress. During that, the HPA axis and sympathetic responses are buffered during this period. And because these responses are harmful during brain development. Next, please. So for the stress hyperresponsive period, the maternal care functions as a shield against aggressive stimuli, creating a less stressful environment for exploration and development. So a healthy parental boundary leads individuals able to recognize emotions linked to acceptance and care, displeasure and reprimand. And will be a guidance for solo environment exploration that is essential for identity formation. Instead, maternal deprivation experiences creating a hyperreactivity of HPA axis. Next, please. The stress hyperresponsive period starts in human babies around the first years of life and apparently lasts throughout childhood. Hippocampal development is completely within the first 2 to 3 years of life, but frontal development occurs during adolescence through young adult life. Next, please. Now I'm going to show a video demonstrating this maternal shield. It's a video from the Professor Suomi, and he has a lab at Washington, D.C. It's a lot of monkeys in an open field. And here the mother and the baby, and it happens a fight with other primates around here. And she will try to distract the baby. Please, can you click on the move? So the mother, and she will pick a flower and try to distract the infant. And when the commotions go away, he let the baby go to explore the environment. So she is acting as a maternal shield. Next, please. The development of some self-representations are only induced during critical periods in the 2 and 30 years. And babies' brains must interact with a stable environment to become a stable personality. And it depends on the protector parental shield. Babies count only with their procedural memory for that, because declarative memory will develop posteriorly. Next. The development of the ability to recognize their own and other affective states and emotions is interactive. Mother and babe have innate mechanisms, and these mechanisms interact with each other. Next. Again, I'm going to show you a newborn reflex of facial imitation that we have also in humans. Pode passar. This is a newborn. He has just born, and the researcher is trying to make eye contact with him. He's trying to understand what's going on. He has just born. And once the research make eye contact, he start to show the tongue to them. And he's trying to do the same. He doesn't know it yet what muscles I need to move because he has just born and he's trying. At the end, he will put the tongue. Oh, he's trying. He puts the tongue. Next, please. So this mechanism is innate, and it has some function. And we also has this mechanism, this reflex. Emotions development emotions are linked to these experiences, will guide the individual to develop his psyche and his ability to distinguish dangerous from hospitable situations. That is fundamental for individual autonomy. Next. But how do early trauma could interfere on risk for PTSD development during adult life? How traumatic experiences previous to verbal phase become a traumatic memory? Next, please. So we took a look on memory. Memory, in fact, is not a real thing. It's a concept. It's neither a function nor a property of a neural system. It's a relationship between a fact and observer. It's a characteristic of human mental processing. Human memory works in associative manner. New experiences are associated with previously acquired experiences and emotions attached to them. Next. So we can define memory as the ability to recognize the ever found, the lived. Next. The memory acquisition is emotion dependent. Highly emotional experiences determine higher degrees of attention and concentration. Highly emotional experiences are difficult to forget. Cognitive details are forgotten, but the emotions remain. Procedural but not declarative memory persists. Next. So procedural memory are persistent. We never forget how to ride a bike. Traumatic procedural memory, so, is persistent and intense. Procedural memories from traumatic parental bonding contaminated further interpersonal relationships. Next. The opposite, the declarative memory, is for events, facts, words, music, all we acquire during the life from experiences and learning that can be declared or brought to mind as a mental image. Next. So, because of that, both of them has different biology. Declarative is dependent on integration of prefrontal and temporal medial lobes, which communicate with anterior cingulate and parietal. Procedural, dependent on premotor, cerebellar, and parietal areas. Next, please. But there are a consensus between authors that study memory. Memories are stored through functional and structural synaptic changes from neural nets related to each memory. Next. How we form a memory. As established mental image has it correlate neural net, but they are not the same. This is important. We have a neural net and we have an image. It's a difference between, as I think, between mind and brain. This establishment depends on the emotional content, as the clarity of consciousness and ability to synthesize many information, which constitutes itself. The synthetic process of all images parts depends on an integration executed by prefrontal cortex. Next. And once we have the memory, how does the recall work? When the prefrontal cortex receives external stimuli, it needs to recognize as a known experience. The stimuli triggers a chain of emotions. The emotions triggered by this new stimuli reactivate the neural pathway formed by a previously acquired experience. Prefrontal cortex synthesizes the recall as a lived fact to the present. Next, please. Another concept that is important is a concept created by Antonio Damasio, a neurologist, a Portuguese neurologist that lived in US. He said that emotions linked to affectionate relationships, conditioned through early experiences, will frame future affective and social relationships, which will guide them to deepen or to reject them. So the somatic marker is a procedural memory also. Next, please. The parental bonding so shapes the emotions related to interpersonal relationship. Healthy parental bonding creates individuals with better self-awareness and their affective needs. And also a better perception of desires and intention of the others. Next. In opposite, dysfunctional parental bonding, like lack of affection, negligence, or excessive control, creates subjects with difficulties to recognize their own needs and desires, as to perceive the other's intentions and desires relate to them. Next, please. This is another video, and this is an experiment, and it's showing a mother and her baby, a very young baby, communicating each other. In a moment, she will turn back his face, and when she's back, she has a still face, and the baby immediately perceives it.
The still face experiment what the mother did was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
Next, please. So we are able to see how strong is it and how quickly the baby reacts to the mother communication. And now I'm going to show you another video and showing the importance of eye contact and all this innate mechanism that I showed before, and has a function. Professor Swami did a lot of experience in showing that with more eye contact, that the better will be the social adaptation of this primate when he grows up. Please, the video, please. The mother is trying to make eye contact all the time. I think that human mothers do the same. I'm sure. She's forcing him to look at her because it's important. It's okay. Next, please. Pathological parental bonding probably creates an efficient protective shield. These babies will have a hyperreactive response against other persons, independently of their intentions. Next, please. Early traumatic experiences contaminate interpersonal experiences with a somatic marker characterized by displeasure, feeling of dissatisfaction, even when the subject acts adequately in the search of its desire. Increases the chances of problematic relationships, personality disorders, hyperreactivity to stress, and risk to develop some mental disorders like PTSD and major depressive disorder during adult life. Next, please. Social interaction forces the individual to make many choices to adapt socially. These choices depend on reasoning and decision. Social interaction implies on many possibilities against a single situation. We can make a confrontation, approach, or having an indifference for another person. But each one of these choices will have consequences. Once we analyze all of possibilities, we make a decision to act, but which could be a reflex or about a point of view. Next, please. But in a daily basis, we have a large number of choices that make it impossible to rationally choose one possibility, as René Descartes said. It's impossible to think all the possibilities. Damasio said that there are a pre-selection based on welfare or malaise triggered by each options. And these emotions, that is the somatic marker, were determined through through experience learning stored as procedural memories, the somatic markers. Next, please. So early trauma has consequences on decision making. Decision making on social relationships could be disturbed by somatic markers, distorting individual options. Social maladjustment, dissatisfactions, and damage on self-construction. Next, please. Children victims of abuse or negligence has less accuracy to identify emotion compared to health controls. They need less perceptual information to identify rage expressions and has difficulties to recognize sadness and regret expressions. Next, please. Maltreated children recognize faster fear expressions compared to healthy children, independent of PTSD presence. Next, please. Procedural or declarative memories have different mechanisms. So we need different interventions for each one of the memories. We can ask, is there a somatic marker? Could we intervene on this somatic marker? What differs the perceived from the spoken? Next, please. Human development is a long process and needs a health environment proportioned by health parental bonding. Learning and development is initially based on enduring and resilient procedural memories. Next, please. Early trauma may lead to impaired social skills. Extreme traumatic events during adulthood promote an stress reaction, which could save individuals' life. But if the stress persists, the patient can develop PTSD. Next, please. If the stress response persistent, will lead to pathological images, thoughts of inability to act to avoid the traumatic event that could happen again at any moment. but which now become imaginary as the event has already happened. The patient has doubts about his ability to act or to decide. The memory reverberation confounds imaginary and reality, losing the sense of reality. The apprehension of real and present is disturbed. This is a clinical, the clinical presentation of a PTSD patients. Next, please. Subjects with a history of early trauma and or parental bonding, poor parental bonding, have previously difficulties to get sense of reality, mainly on interpersonal relationships. Traumatic events could potentiate this impairment, leading to intrusive thoughts and dreams, sense of inability, insufficiency, and anguish. Next. Thank you very much. So, questions? Okay. As I decide to do something different, maybe a mess.
No, quite the opposite. I think that you did we all had, some of us were in tears, some of us were like wanting to hug the kid. And, but I also want to ask you, because you do clinical interventions. So tell me your translation from this into the work that you're doing. I know it's a very broad question, but you've been working in this area for a long time. So tell us your clinical implications of what you talked about and your data.
I'm doing also psychotherapy, and also I'm a psychiatrist. And for this somatic marker, or all these distortions and inability to perceive the others and the patient's own desires and intentions, we have to promote it in a healthy relationship with him. I think that more analytical, psychoanalytical therapy in a more traditional way is not efficient, I suppose, for them, because they need first more interactive and not interpretation. So we have the therapists need to teach them, to the patients, how to deal with their emotions and what they are provoking in the other. Something that some people that work with borderline with me are doing the mentalization process. It's a kind of technique. That's when the patient is in the therapists are trying to say to patients what are he creating in the other, and something like that. But I think that we have to try and discover new kinds of psychotherapeutical tools to deal with it, because this is a pre-verbal phase, something that is acquired pre-verbal.
Thank you. That was the most coherent explanation of things that we've looked at in different ways that I've ever heard. It was very, very enlightening. But you do interpersonal psychotherapy. What could that be except like a bandage on a big sore? Is there any role for that?
What is the advantage? I think that interpersonal therapy is very useful, because the therapist is a kind of partner in this for this patient, and we are like a mirror to him, but it's a mirror that's trying to correcting the distortions. And we have the role play as a technique that's very useful when we demonstrate to the patient how he's talking, how is so dissociate the verbal from the affective. So So it's very useful because it's an here and now therapy that is useful for those patients that have traumatic experiences. We have worked with them using IPT. I have a psychologist that I think is not here, Aline, and she has a lot of experience with this kind of patients using IPT. But we didn't, we are developing it, we didn't test it yet. I don't know. We have to test it.
Congratulations for your presentation. And I would like to know, you mentioned the procedural and the declarative memories as important for the personality development. And the early trauma was your study. Is it, I don't know, if you have a trauma during the period of, we have the main procedural memory for the birth until the 5 years old, 4 or 5 years old, and then we start the development of declarative memory. In your opinion, trauma during only the phase of procedural memory would be this absence of declarative memory would be protective for the subject, because without the declarative memory they would have only the hyper-responsive of HPA axis, and then without the memories of declarative. I don't know if I've made myself on this.
I don't know the exact answer about what
if there is a difference.
Yeah, there is difference in timing depending on when the trauma happens, like prenatal and adolescence. Mainly the response is hyperreactivity of the HPA axis. And during this period of preverbal phase, the response is opposite side, is hyper responsive. So there are differences when the trauma happened. But I don't think that preverbal phase, if the trauma happened during the preverbal phase, is protective. But I think it's worse because it's more, as like I said, procedural memory are persistent and intense, and you affect in the future in all relationships, because it will be like a somatic marker interfering on individual perception of the environment and also of his self-perception.
Even with a further good education and even parental presence during the
I don't know. I think
this is very difficult to.
These are reflections about what we saw in clinics. I think that it's open a field for a lot of experiences and to test how to do with what we can do about it.
Thank you.
Okay. So we are finishing, and we have 50 minutes. 50 minutes for interval. Thank you very much.